Good afternoon. Good afternoon, everybody. And I know I'm really happy that today's oration that is installed by me and my son, Dr. Rohan Palshetkar, uh, for ISAR is being delivered by Amit. You know, the whole idea behind the oration was that we are past presidents and thought that we should give back something. You know, as a young girl, I was always very fascinated by medicine, the stories, of hope, resilience, and transformation which actually take place. So medicine has always been my passion. And once I got into IVF, it was like no looking back. There's absolutely, these last 30 years have been fabulous. And this oration was installed with the idea of sharing knowledge, sharing, stories, and all our people who are doing fabulously well and discuss new innovations. And those will transform our lives. And that was why this oration was really instituted. And I really thank all of you all for the love, affection, and of course, the ISAR full managing committee, for giving me this opportunity. So thank you for being there. And Amit, thank you for delivering this oration. I'm really happy that my very, very good friend is going to deliver. So now, since it's an oration, we would like to introduce you. Dr. Sujata Kar will do the needful. Dr. Dhurusha.
Anyway, I'm happy to introduce Dr. Ameet Patki, who was a very, very efficient Secretary General at the ISAR when I was the president of ISAR. I'm happy to introduce him because I know him personally very well. We worked together for a year, and the most efficient secretary you could get, and now even a bit better president. So Ameet has been in the past medical director of ICAN Fertility Associates. He's currently the medical director and worked earlier with the Reliance team. After completing his post-graduation, he went to the UK where he obtained his MRCOG and did his fellowship in assisted reproduction before coming back to India in '97. With over 50 scientific publications and several book chapters to his credit, he's an editor of 3 books in the specialty. 2 international patents to his credit in infertility and embryonic stem cell research is with him. And during COVID times, he conducted an online series called Living Legends with Dr. Ameet Patki, which had a live viewership of over 18,000 and a successful YouTube viewership. All of us were looking for something to do during our COVID days, and we spent it well. He has been the chairperson of Perinatal Medicine Committee at Foxy. I was the chairperson of Perinatal Medicine many years ago. So it's been quite coincidental that we have been working together on various platforms. And he's also been a TEDx speaker since 2017, the first gynecologist and infertility specialist from Mumbai who spoke on TEDx. He's been the recipient of the Foxy Korean Award as a Young Scientist Award and the MOGS Dr. Ganatra Award. Various awards at the Mumbai Society, where he's also been the president, and currently as president of ISAR, to over 6,000 members for 2 years from 24 to 26. This is his second innings as president, 1 year over, second year in duration. So lots more to see from you, Amit. Go ahead with your oration.
Thank you very much, and a very good afternoon to you. Thank you, chairpersons. I think all those on the stage have a special connect, right from Dr. Sujata, who beautifully conducted the annual conference last year where I was installed. As Dr. Dhurusha said, I was a secretary and I learned fine nuances about how to manage an organization like ISAR. I still remember I used to go with a paper and pencil to her office so that I could erase what I thought was right and she would tell me what to write was right. Dr. Rajul Tyagi as the organizing secretary of this wonderful conference. And lastly, Dr. Nandita Palshetkar, a very dear friend, and in whose name this oration has been instituted. Nandita, as my sign of gratitude, I've worn the tie that you gave me when I got installed at Bhubaneswar. I hope you remember that.
We all chase unicorns' big dreams, rare opportunities, that one in a million shot. But the hardest part, taking the leap of faith. You may not see the safety net, but sometimes the only way to know is to jump. Chase the unicorn. Take the leap. You just might fly. We all chase.
Ladies and gentlemen, allow me to present to you my oration topic, Chasing Unicorns, the alloy and reality of new trends in assisted reproduction. I've taken the metaphor of unicorns because unicorn is the mythical creature. As fertility specialists and as doctors the world over, we strive to improve our success rates. We strive to do something better. We try to attain the unreachable. But at the same time, I think it's very important and our responsibility to balance it with the realities that are there in our life. So this unicorn is a mythical creature, someone who's amazing, who's hard to catch, as trying to get 100% success in my clinic or a rare find. And chasing the unicorn is something that we all do. We all take this leap of faith, try and introduce new technologies, new protocols in the allure that we would try and improve the success, but the reality is something which is very different. Look at this number of publications that have happened in the ART circle, and you can see over the last 3 years there has been a sudden surge, which indicates that there is a surge in research and, more importantly, interest in ART technologies the world over. But let me take you to some changing paradigms, and the first and the foremost, because I have been closely associated with luteal phase, is a changing perspective in a decade. Way back in 2012, the ASRM committee report came up with the clinical relevance of luteal phase deficiency. They went on to say that while progesterone is important for the process of implantation and early embryonic development, 3 years later, they changed their mind. And the committee opinion said current clinical irrelevance of luteal phase deficiency. By then, we had all got hooked onto progesterone, realizing very little that micronized progesterone does very little to threaten miscarriages and to recurrent pregnancy loss. But as we all then mature, 5 years later, the same ASRM came up with a committee report of talking of diagnosis and treatment of luteal phase deficiency, a committee opinion, which meant that now from the highs to the lows, we had now matured over time and we knew when to use progesterones and in which cases. However, the fact still remains that idiopathic luteal phase defect has not yet been proven to cause infertility. Let me give you another example. In 2013, the NICE guidelines stated that IUI is not recommended for couples with unexplained infertility, male factor infertility, and mild endometriosis. Now, this was based on 2 seminal papers that were released that year. One from Siladatya Bhattacharya, who conducted a pragmatic randomized controlled trials comparing expectant management, clomiphene citrate, and unstimulated IUI in unexplained infertility, and the FAST trial, which was a randomized clinical trial designed to determine the success of gonadotropin or FSH IUI therapy in infertility in the younger group of 21 to 39 years. And what happened after these NICE guidelines? IUI rates dropped 50%. The incidence of doing IUIs in IVF clinics dropped, and most of the patients were pushed into IVF because NICE guidelines said that in unexplained infertility, IUI has no role. So large number of patients got success in IVF, but little realizing that they didn't need IVF in the first instance. It was only in 2018, and we have Yin Chong with us here from Southampton, who came up with the best practices papers and said that IUI does have a role in modern ART, and it has to be used carefully in certain patients, and then the rates of IUI in the last 5 years have slowly gone up in the United Kingdom and in Europe. So when we talk about evolution of a concept, my central question to you is, are all modern trends transformative, or are they transient distractions? Because we get distracted when a new trend comes, we all tend to follow that, and then 5-10 years later we realize that it wasn't meant for all. As one shoe doesn't fit all, it is the same thing here, that we have to understand that trends are to be taken in their context, have to be taken for the particular group of patients, and may not be suitable for all patients desiring pregnancy. The most famous example I can give you is emerging technologies, is PGTA. And in the morning, we have Prof. Ginsberg from the ASRM, who spoke about the same. Now, PGTA was designed to exclude aneuploidy embryos, because that way you got a better implantation rate, and more importantly, lower miscarriage rates. However, after a few years, we have realized that PGTA is not for all, because there is mixed evidence on impact for younger women or good prognosis patients. Which means that amongst women who have got 3 good quality blastocysts, that is a good prognosis for live birth, conventional IVF resulted in a cumulative live birth rate that was non-inferior to PGTA. So look at this graph, and this graph actually shows you that the absolute difference of 4.6 is towards conventional IVF, which meant that conventional IVF gave us a better cumulative pregnancy rates than doing PGTA in all patients, especially in good prognosis patients. Another emergent technology was freeze-all strategies. We picked it up, and we all proclaimed that our clinic is soon going to be a freeze-all clinic. It has its advantages. It bypasses the deleterious effects of ovarian stimulation, mainly hyperstimulation, and the effect that it can have on implantation because of its effect on the endometrium. So it is effective in cases to prevent hyperstimulation, but understand that it is a context-dependent one. So freeze-all technology, as I said, was initially heralded as beneficial. It's only after some time we realized that perhaps it has to be used only in the context of hyperstimulation, and that is something important. Otherwise, we are doing over-treatment. We are freezing embryos. We do not know the side effects or the epigenetic changes that can happen in unnecessary freezing embryos, and trying to put them back in a normal cycle. This is a New England journal which spoke about fresh versus frozen embryos for infertility in PCO patients. And they concluded to say that FET was associated with a higher rate of live birth, a lower risk of ovarian hyperstimulation, but understand there's a caveat: higher risk of preeclampsia after the first transfer than that was present in the fresh embryo transfer. So only in the context of PCOS and in cases where you suggest or think that the patient will have hyperstimulation would freeze-all technique help, because in those cases, an FET gave you a much better and, more importantly, a safer outcome. But it is something that needs to be discussed with the couple because they are at a high risk of having preeclampsias. What about frozen and fresh transfers in ovulatory women? So the live birth rates did not significantly differ in fresh or frozen embryo cycles amongst ovulatory women with infertility. But yes, of course, the frozen embryo cycle always gave a lower risk of hyperstimulation. So in normal ovulatory women where IVF is done, you need not go for all freeze. The fresh will give you as good and as safe outcomes as possible. Another emerging technology, single embryo transfer. We know it largely helps to reduce the risk of multiple pregnancies, and I think this is the way forward because we do not at any cost want to have increased maternal or neonatal morbidities. And comparative results have shown that now with better cryopreservation technologies, we can freeze better, we can freeze quickly, the process is not tedious, and the thaw rates are equally good. What about endometrial scratch? At one time, it was mandatory in the NHS in UK that all patients who underwent IVF should have an endometrial scratch in the previous cycle. But Ben Moll has a very good editorial where he has said it is time to stop scratching. It is meant only in cases where you have recurrent implantation failures and not to be done for every IVF patient. Role of assisted laser hatching. From 2012, when the ASRM Practice Committee guidelines spoke eloquently about laser hatching, and we all fell for the trap. We went and bought large number of machines. And now in 2022, the same ASRM Practice Committee says that laser hatching should not be routinely recommended for all patients undergoing IVF. There is insufficient data to make recommendation even in those small group of selected patients, such as those with poor prognosis. What about the use of embryo glue? Weren't we all conned with this, that we used the embryo glue for transfer? Now, it is very clearly saying that embryo glue for embryo transfer does not improve your live birth rate, a very strong prospective randomized trials. So when we look at novel insights from research, innovations to improve outcomes should be there, but in select patients. And it is important that every technology should not be used for all, but should be used only for that context. One group of patients is endometriosis. We all know that this is an enigma still to be solved. We are still not clear about its etiology. We know it is multifactorial challenges, and that is a reason why we need a tailored approach to each patient. In addition to the symptoms that the patient addresses and the distortions that can happen in the pelvic anatomy, we have to consider inflammation, adhesions, and the prospect of decreasing the ovarian reserve if we do some heroic surgical technologies. At the same time, we know surgery and ART remain the mainstay of treatment, and surgery should be offered only and only to patients who are symptomatic, in patients who have got deep infiltrating endometriosis, which is causing obstruction either to the GI or the urinary tract, or in places where you think accessing the ovary at the time of oocyte retrieval is going to be a difficult job. Barring these three conditions, I think it is very important to treat them medically, try and do egg retrievals, try and do egg freezing, embryo freezing, and then go ahead. The use of anti-inflammatories, antioxidants really do not have much scope. The future lies in miRNAs. The future lies in stem cells, particularly in endometriosis. What about emergent technologies in reproductive pathologies, in uterine anomalies? And the first is uterine septum. We all know the septum is responsible for recurrent pregnancy loss in a large group of patients. And hence, septal resection will improve the rate of recurrent miscarriages. But there is insufficient evidence to conclude whether a septate uterus is associated with infertility, and more so if it is found coincidentally. Do not try to remove the septum. Do not try to remove septums which are less than 1 centimeter in size. So hysteroscopic septal incisions to patients with a septum and history of recurrent miscarriages, even in those patients, I think it is important to counsel. It has to be a shared decision, because we know sometimes the patients can land up with adhesions and worsening of the uterine cavities. What about fibroids? This was an excellent paper which was published 25 years back in the Human Reproduction of 2001. And it said that the mechanisms by which fibroids may reduce implantation potential of an embryo are unclear. However, there are proposed theories such as vascular changes, hyperplasias, atrophy, or inflammation of the endometrium, or the presence of local transmitter substances in the myometrium. And this spoke about how intramural fibroids can affect infertility, particularly implantation. The study demonstrated that an intramural fibroid halves the chances of an ongoing pregnancy following assisted conception. But did we listen? No. We spoke only of submucous fibroids, and we allowed the intramural fibroids to remain. And now, 25 years later, in 2024, there is a beautiful paper which speaks about a debate about the hypothetical mechanisms and tells us the same thing that was discussed 25 years back, that fibroids can cause sexual dysfunctions, prolonged menstrual bleeding can decrease sexual urge, it impinges on the tubes, it causes irregular uterine contractions, it causes decreased environmental for implantation, it disrupts the vaginal uterine microbiome and decreases implantation. So 25 years later, we are still being told the same thing, but we haven't still listened. Initialization of ovarian stimulation, predictors of ovarian response. I think as fertility specialists, we all try to give a safe maximum response that we can do for our patients to ensure that we get a good response, and that we base mainly on our experience. It is very important that we progress towards individualized treatment, and this was something that Bart Fauser spoke in 2007. And 2021, we have again a large meta-analysis speaking on the same thing of how we can individualize ovarian stimulation in IVF. Basically, we go on our experience, we go on our patient's age, BMI, and coexisting problems, and the reason why we are doing IVF. But as yet, there is no algorithm that we can use which will help us to decide the initial dose or help us if we need to increase or decrease the dose during the stimulation. So in 2025, Is the promised land of individualized ovarian stimulation reached? Unfortunately not, because we still have to develop algorithms which will help us to individualize ovarian stimulation on the basis of standard algorithms. And I think there is one algorithm which can help us, which is the UNOLS guide, which talks about in which patients we should intervene and in which patients we should allow expectant management. A beautiful algorithm created in the Scandinavian countries. Unfortunately, we are not sure if the same algorithm can be used for different ethnic groups, and this is something that needs to be tried. Because when you talk of unexplained infertility, diagnosis of exclusion leads to potential overtreatment. So you may sometimes unnecessarily overtreat patients because you still do not know which patients would manage it on their own and which patients may need only mild treatments or which may need the full ART treatment. So using models like the Henol's model guide to optimize your interventional strategies is something that I think should be added to our next research or to something which will help us to reduce unnecessary interventions, particularly for the large group of unexplained infertility. But ladies and gentlemen, just give it a thought for 1 second. Live birth, is it the ultimate metric? Or we have to go beyond? We have to push ourselves to see whether the treatment evaluates and helps for maternal and neonatal health holistically. As yet, we do not know what is going to happen to these mothers who have been subjected to various treatments. We do not know what will happen to these children who are born with epigenetic changes, be it frozen embryos, be it embryo biopsies, be it PGTAs. So I think it's important that we push our primary outcome from live birth rates to maternal and neonatal health in the long run. The next film I'm going to show is, then do we kill the unicorn? Do we kill that realistic thing that we want, that we want to achieve something? And this is a movie on
showing
the
me
death
something.
of a unicorn.
I get this feeling I don't think we're supposed to be here.
It's a story of a father and daughter, Rudd and Ortega.
Fine. I will sit there and smile.
Inadvertently kill a unicorn when they're driving to a retreat.
I need you to act
They
like
pack
everything
the
is fine.
unicorn in their car. They go to Rudd's boss, who takes advantage of the miraculous powers of the unicorn.
Here's hoping we kill Bigfoot
So
on the way
ladies
home.
and gentlemen, there's a metaphor here. We are Rudd and Ortega, and our boss may be the new technologies or the companies that drive these new technologies. So we have to be very careful that we do not kill the unicorn in us. We continue to strive. So where do we strive? Where do we put our next goals? I think our next goals should be on AI and the use of AI in ART to highlight the evolution and impact AI has had in different fields in infertility that could improve our outcomes, more importantly, reduce the cost, and positively impact our clinical care. Then chasing the unicorn can be in two directions. One is overcoming a complete lack of gametes without donation, which means you have stem cell differentiation from embryonic stem cells, which has been established in murine models. Gamete developments from embryonic stem cell is a prime example of a technique which not only the outcome but the means to achieve also should be considered. We know that although to maintain the embryonic stem cell and induce differentiation, our knowledge remains poorly understood, while effectiveness, safety, and tolerance would need rigorous testing before clinical use. We also have to take into consideration religious and ethical before we proceed ahead with embryonic stem cell. More importantly than embryonic stem cell is restoring fertility. Till now, till this date, we all practice techniques that do not cure infertility, we just overcome it. I think artificial gametes would similarly that you have generated with embryonic stem cell would further need assisted fertilization. The most appropriate unicorn that you should chase should be to restore fertility in that person. Gonadal transplantation after cryopreservation, which is being now investigated for cancer survivors, I think gives us the lead. And live births have been reported from orthoptic ovarian transplantation, both spontaneous and IVF assisted. Gene therapy is the unicorn that we should chase. It is valuable for fertility restoration. The genes identified are quickly getting noticed, and we are building up a bank as far as genes are concerned. Instead of creating embryos to develop embryonic stem cells, why not look at the unicorn of induced pluripotent stem cells, which are adult somatic cells which have been programmed to behave like embryonic stem cells. So the concerns, religious, ethical, go out because these are pluripotent cells from the same person where you can develop the gametes. So these are more desirable than embryonic, but currently the induced pluripotent stem cells display abnormal regulatory pathways and aberrant imprinting patterns. So it will be quite a few years or maybe decades before we can offer this as clinical use. But AI will help us in a digital ecosystem for personalized care, the power to predict what should be your starting dose, optimizing the IVF process, deciding which embryo to transfer, and extracting images to guide decision making. To end, last year's words belong to last year's language. And in next year's words await another voice. And to make an end, ladies and gentlemen, is to make a new beginning. I thank you very much for the patient hearing.
That was really brilliant, Ameet. I wish there would be more such ethical issues brought out in our programs. And I think all of us need to give him a standing ovation for this wonderful, wonderful talk. Congratulations.
I would like to invite on stage